All right, let's go ahead and get started. Again, welcome everyone to our February 2026 Wisdom Study Community Forum. Um, as I mentioned earlier, for those of you who have just joined, please do introduce yourself in the chat. We always love to see where people are calling in from or zooming in from. And if you've been, this is your first time on one of the forums or you've been here before, welcome. We are excited to have our next forum this month and should be very informative. So just a couple housekeeping items before we get started. So the format for today's session, we do want to hear from you. These are intended to be forums that we get to hear your questions, what topics you might want to listen to next. We do ask that you raise your hand or put in the chat if you have questions, and that can be anytime throughout the discussion. So if there's a timely question, we'll try and interrupt the speaker and ask that question when it's relevant. But if you're not speaking, if you could please mute yourself just so there's not any background noise. And then we do record these so that we can share them with those who weren't able to attend. And at the end, we do have a short post-meeting feedback survey that we'll ask you to fill out. And that just allows us to understand sort of how you liked the session, how the topic was, but also if you have suggestions for future session topics as well. As I mentioned before, these forums have been going on for the last several years, and our mission really is to move together toward equity and better outcomes in breast cancer for everyone, and actually breast health and women's health for everyone. We have had a variety of different topics. This writing now is getting a little too small to even see on the screen. So we have had a wide variety of topics over the last few years and encourage you to check out the YouTube channel if there are any topics that you might want to revisit and listen to on your own time. But for this month, we are going to be talking about understanding breast biopsies and pathology. So this is a topic that hopefully many of you won't have to experience having a biopsy, but we know that it's relatively common for people who are screening. And so we wanted to go through sort of what the basics are, how do we evaluate and look for breast disease, what are the techniques, and also what are we trying to do next in the wisdom study to incorporate the information from your actual breast tissue to help us improve our risk assessment. So I'm very pleased to introduce my colleague, Sandy Borowski. Sandy has recently moved to UCSF from UC Davis, though we collaborated for a decade while he was at UC Davis. He is a professor and vice chair of pathology with the UCSF Cancer Center in the School of Medicine. He's led our Athena Network site at UC Davis and our Wisdom Study site at UC Davis for the past decade or so, and also has worked on many, many other research projects and research studies in collaboration with our teams here at UCSF. So we are thrilled that he has now joined the faculty at UCSF. He's a little closer in contact with us, so easier to find him on campus when we need him. But really pleased to have him present today and give you a background on the work that he is doing and that we're doing together in the wisdom study. So with that, I will pass it off. And Sandy, I have your slides, or if you want to show them, I can stop sharing.
It's probably easier for me to just share.
Okay, perfect.
Thanks very much. I'm very happy to be here. I really enjoyed being at Davis, but more and more I was working with you guys, and so more and more it made sense to come on over, across the Bay Bridge to join you all. And I'm very happy setting up the lab here. All kinds of new people I'm meeting that I didn't know before, even though I know you guys really well. And so it's been a lot of fun already, and I'm looking forward to a good, next 20 years or so of great research. All right, let me share.
Hi, everybody. Sorry I'm late.
Hey,
Hello.
Laura, by the way, largely responsible for making sure that my recruitment happens. So thank you, Laura.
You're welcome.
All right. I'm going to
All
start
worth
with
it.
some, yeah, all
All
good.
all good things come to he who waits.
What happened? Come back.
We're good. We see it.
You see it? Good. Okay,
Yep.
I'm going to start with basics. What is cancer? What is the definition of cancer? This top definition is the definition from Merriam-Webster online. I've done a little highlighting just to make it a little easier to think about. But cancer is defined as a malignant tumor of potentially unlimited growth that expands locally by invasion and systemically by metastasis. And so there's a couple of like words that themselves need a little definition in here. First of all, I actually don't like using the word tumor. It's not specific enough. Tumor just means a mass or a lump, which, cancer can be a lump or a mass, but it also can arise without making a lump or a mass. And just think about, for example, leukemia. Leukemia doesn't really make a mass, it circulates in the blood, but it's still cancer by any definition. The word malignant is an important one, and we're going to talk about that a little bit today. So that means that um, it has the potential for causing harm, and among the harms that it can cause, if it's malignant, are death, of course, so mortality. So morbidity and mortality are things that we talk about in the context of cancer. And the way that it does that is by these two properties that they describe in the definition, that is local invasion. So you can imagine a tumor causing a lot of problems by invading locally and invading into important tissues. I like to point out brain cancer is in this category. Brain cancer invades into very valuable territory. And so brain cancer doesn't have to metastasize to cause problems or to be malignant. It just has to invade locally. Um, but for breast cancer, the main cause of mortality, because people like Laura and her colleagues in surgery and radiation oncology have gotten so good for most patients at treating the local disease, it's the metastasis that's the real problem. And so those are the things we think about when we catalog or categorize our cancers in terms of their ability to grow rapidly through local invasion and or their ability to metastasize to distant organs. And in the bottom definition, I changed the word tumor again because I didn't think it was very specific to the word neoplasm. And neoplasm is sort of medical speak. In medicine, we've stolen words from Greek and Latin in order to try to be as specific as possible. And so neoplasm means neo or new, and plasm means growth, so new growth, a malignant new growth. Um, Tumors theoretically can arise for other reasons, and that's why I say it's a little less specific. But this word malignant is a really important one to me because we now know that cancers really are not all created equal. Some have a lot of malignant potential and can be quite lethal. But some things that we call cancer may minimally invade locally, but not have metastatic potential, for example. And so they really don't have significant malignant potential. They can also grow very slowly, um, so that even in the local setting, they may not be problematic. And we're going to talk a little bit about what we know about that today. So, you can think about cancers and their potential for malignancy in different ways of substratifying them into these categories that we think of as being reflective of their real potential and their eventual outcomes. And importantly, we've learned that it's not enough to just look at cancer cells. We do look at cancer cells, and there's specific types of cancer cells. They have specific what are called oncogenes or mutations in genes that lead to the neoplasm, the new growth, the uncontrolled growth. But they may arise actually in different cells of origin. So if a mammary epithelial cell still has stem-like properties, that may give you a different kind of tumor than a mammary epithelial cell that's become a differentiated lobule lining or potentially milk producing cell. These properties also include faster or slower growth rates in the tumors and faster or slower mutation rates. So if you think about the way cancers arise, it's sort of like evolution. It's sort of like survival of the fittest, where the cancers that grow the fastest and grow better than their neighbors are the ones that win out. And so you might have um, some cancers that are able to evolve faster because, for various reasons, they have a higher mutation rate. So if their mutations happen more frequently, you get more chance of them evolving a new property, which is survival of the fittest compared to its neighbor or even its parent cell. And then we also have to think about external properties, the properties of the environment of the host where the cancer arises. And um, these features can lead to differences in our ability to detect the cancer early versus late. Does it cause symptoms very early? Does it not cause symptoms? Does it hide and not show up on a mammogram? Or does it show up very readily on a mammogram? But we also think about other ways that cancers um, are going to have a better chance of being malignant or a lower chance of being malignant based on, can they evade your immune system? So your immune system is a very important blockade to development of new cancers. And many of the mutations that we all get all the time are readily taken care of by your immune system without causing problems. But in order to be a malignant cancer, that cancer has to figure out ways to evade that immune surveillance, immune detection. And then, of course, one of the main um, factors in considering the outcome of any cancer is, how did we do on treatment? And how did we do on the timing of that treatment? And if we do very well on treatment, then even a very malignant cancer may not have a bad outcome. And so those are all part of the background that we talk about. Almost all of this is done now from core needle biopsies, and I was going to talk a little bit more and show you how that's done, but we're gonna talk about this kind of more strictly in the context of mammographic screening and the Wisdom trial. So in our core needle biopsies, the things that we see that lead to core needle biopsies are sometimes we see on the mammogram calcifications. Um, Calcifications can occur in cancers. They can also occur in benign disease sometimes. And we want to figure out which it is. So we do a core needle biopsy to find out. Sometimes there's obviously a palpable mass, something that you can feel in the breast, and that can be a reason to do a core biopsy. We usually add to that some radiology, but sometimes there's not a palpable mass, but we see something on our imaging, either our mammogram or by MRI, which give us slightly different looks at the breast tissue. And when we see something we're suspicious about by imaging, we'll do a core biopsy. And whenever I sign out a diagnosis from a core biopsy, I have to always address whether it looks like we got whatever it is that we were going for. Here are different strategies of doing core biopsies, and we like to um, do our best to understand how big a tumor is, even though we're only doing a core sample. If you think about where you took that core, it might be tangential to this sort of falsely circular shaped object I made. So if you get it tangential, your measurement may be an underestimate. But if you get it right through the center of the thing, then the measurement should be an accurate reflection of the largest diameter. And so this is a way for us to begin to gauge how early it was, or how large is the tumor at the time that we detected it. And that's what we talk about when we talk about breast cancer stage. So the stage of disease means how big and how far widespread is it when we first find it, and how do we score it? And so we measure the size of the tumor. We measure that size in the largest diameter. Sometimes we look for irregular shapes. Cancers don't necessarily always make these nice sort of uniform jaggedy black spots. Sometimes they form more irregular shapes in space. And we do our best to measure that size so that we can compare one patient to the next based on the size of the tumor. The other thing we look for is whether the lymph nodes are involved. And you can see these cute little blue chains of lymph nodes here. And when the lymph nodes become involved, as depicted with these little black lymph nodes, the first to become involved are the so-called sentinel nodes, the earliest draining lymph nodes. And when those are involved, that's contributing to our staging. And then when the tumor becomes more widespread, and here that's depicted as you've got these spots that are now under the rib cage, which is where your lung is. So, for example, if the tumor spreads or metastasizes to the lung, that's a much higher stage. And so we use all these scores. I won't go through all the scores, but the important thing to recognize is that this 2 centimeter mark, 20 millimeters, is kind of a nice mark for knowing sort of whether it's earlier stage or a later stage that we caught it at. Um, why do we care about that? And why some of you are aware that in Wisdom, we used a primary endpoint of stage 2B or greater. Well, here's the reason why. If we take all the patients that we've got, and this is a Kaplan-Meier plot. I don't know how used to looking at these you are, but the way that you look at this plot is that this top line are patients who are diagnosed at the earliest stage, stage 1A. They have the smallest tumors. They have no lymph node positivity. And each patient here is one of these little up and down ticks. So you can see there's lots of patients here. It's almost wall to wall up and down ticks. But then the other way that we look at this is whenever there's an event that leads to, in this case, survival, mortality, you can plot other things in terms of recurrence-free intervals and other things. But in this case, survival, whenever there's a patient that dies from their disease, that creates a down drop in the plot. And so here we are with our stage 1A disease, and you can see there's almost 0 deaths in this plot out to 8,000 days. Somebody has to do the math for me on how many years that is. 8,000 divided by 365. So that's a lot of years out. And really, what you might ask, what you should ask is stage 1 disease really cancer? If it doesn't have a potential for mortality, is it malignant? And we just agreed that our definition of cancer includes the word malignant. So this is actually a very benign course of disease in stage 1A. Stage 1B is very similar. It's the green and it gets hidden actually by the blue here. And stage 2A is still very good prognosis, but you're starting to see some events. And it's only when you get to, sort of stage 2B and above that we're talking about sort of true consequential cancers that have a significant risk of mortality. Some of these, I mean, the odds are still pretty good when you're stage 2B or even a stage 3A or 3B. You still have a much better than 50% chance of long-term survival from those diseases. This stage 4 at the bottom is the worst stage in terms of prognosis, and that's when the patient presents and already has metastasis to distant organs. So that's kind of the worst case scenario. And there's an open question as to whether it's ever going to be possible to detect these early enough to make a difference. So we all kind of agree catching cancers early is a good thing, but we have to also keep in mind when we're designing studies like the Wisdom trial that if a cancer grows very, very slowly, we are going to be much more likely to find it when it's small and well localized. So a very slowly growing cancer is more likely to also be a stage 1 or 2A cancer compared to a cancer that grows very, very quickly, where there's less opportunity to find it in that early time point. So An important question for wisdom for every cancer that we find in the wisdom study and population is, was it a fast cancer that we were able to catch early? That would be good. That's what we want to do. Or did we just find a lot of slow growing cancers? And so these are sort of important next step questions for the wisdom study. So how do we know the difference? So how do we know that it was a fast growing cancer that we caught early versus a slow growing cancer that we caught, you could say early, but early is a long time span for a slow growing cancer. Well, the first way that we do it is by using not the stage of the breast cancer, but the grade of the breast cancer. And so we've developed a scheme for determining how close to normal does this cancer look? Does this cancer look like it's still almost normal breast, or does it look like it's really kind of evolved to be a, um, a very poorly differentiated sort of a figment of its former self, so that it's spending all of its energy replicating and none of its energy doing what the normal cells used to do. And so we use this scoring system of looking for these oops, sorry, go back one, these duct forming structures. So that's indicating that although this cancer is still making ducts and it still has some polarity to it. So it knows which way is up. And this is what normal cells do, because normal cells line the duct and then they create a space in the middle where the milk can be conveyed. And so some cancers still do that. They still remember that that's how they started out. And when they have a lot of that kind of tubule formation, we give them a low score. When they have none, we give them a high score. We also look at the nuclei. How much does it look like the nuclei are just busy replicating their DNA versus trying to do the work of the cell? And when they get marked variation and they look very dark and full of lots of extra copies of DNA, maybe aberrant copies of DNA, that nuclear pleomorphism we score on a similar scale. And then finally, we look directly at the tumor to try and assess how fast is it growing. And the way that we do that is to look for cells that are in active cell division or in mitoses, and we count them. So we look at what percent of the tumor cells or what density of the tumor cells are actively dividing, and we use that to assess just from the snapshot that we have from that core biopsy, um, how fast is this tumor growing? It's all stuff that I do by looking through this microscope. I look at these little glass slides. You can see my little glass slides down at the bottom, and I put them up on the stage of the microscope and do all that scoring by hand. We've learned to um, create these little guidelines for people to be able to reproducibly score things the same way. And here's a sort of a guideline for looking at the nuclei as they go from very normal looking nuclei to very abnormal looking nuclei. And mitotic counting depends on how big the objectives of your microscope are. And so we've set up this system so that we can be very reproducible from one pathologist to the next, even if we have different microscopes. And then we put those scores together. So the lowest score you could get is a 1 plus a 1 plus a 1, or a score of 3, and we call that grade 1. And the highest score you could get is a 3 plus a 3 plus a 3, and we call that grade 3. And so these are sort of the basics of deciding whether we had early detection of a very sort of bad prognosis, fast growing tumor, or whether we have detection of a slow growing tumor that might turn out to not actually deserve to even be called cancer. It may not deserve that word malignant. And similar to the Kaplan-Meier plots I showed you for stage, this is what you get with grade. So low grade gives you a better prognosis than a high grade. And so the outcomes are also different, regardless of the stage of disease at which this was found. One of the things that's interesting to think about is, okay, if we do a lot of mammograms and do a lot of breast cancer screening, does that change the kinds of cancers that we detect? Does that mean that we're going to detect more of um, the slower growing cancers or more of the fast growing cancers. And so this data, published by another group back in 2017, asked that question at their institution. And what they show, if I'll just zoom up on one thing, is that if you look at the so-called interval detected breast cancers, which is this column, versus the screen detected cancers that were found on mammogram, um, you can see there's a distinct um, difference. You are finding more of the low grade cancers. And if you look at proliferative rate, this is another way of looking at proliferative rate, you see more of the cancers with a low proliferative rate. And so these are I'm sorry, that's this number, 66% versus 47%. So more low proliferative rate, more low grade cancers in the screening population compared to the interval detected or detected by clinical symptoms, usually palpation, but sometimes other symptoms. Um, what else do we do? You guys are probably aware that every breast cancer today gets tested to see if it expresses the estrogen receptor, the progesterone receptor, and a surface molecule called HER2. And the reason that we test every breast cancer is that these biomarkers, these markers give us an indication of what might work for treatment. So if a cancer still expresses estrogen receptor the way normal breast epithelial cells do, there's a good chance that it will respond to a therapy directed against the hormone stimulation from estrogen. So we use blockers of the estrogen receptor in patients who are estrogen receptor have cancers who are estrogen receptor positive. Similarly, um, about 10 or 12% of all breast cancers overexpress this surface molecule called HER2. And when we first discovered that, we discovered that that actually meant that they were poorer prognosis breast cancers. They were faster growers. But the nice thing is we've developed drugs against this. Trastuzumab or Herceptin directly targets this cell surface molecule, and we now have new generations of drugs that target that surface molecule, so that now a HER2 positive breast cancer has a better prognosis than a HER2 negative breast cancer. Again, all done with me busy at my microscope. Um, Here's what some of that looks like. We've worked very hard to have high sensitivity estrogen receptor antibodies. We've tried very hard to be reproducible about how we report those stains, but we still have to beware of artifacts. But this brown color, this dark brown color, indicates a nucleus of a cancer cell that has expression of the estrogen receptor. And sometimes it's a bit more faint, but even when it's faint, we think these tumors have a good chance of responding to the hormonal therapies. This is what the HER2 testing looks like. We actually have two ways of testing it. We can look at the cells, and here are cells that have a high level of expression of HER2. But we can also look at the DNA using these colorful probes. And so here's chromosome 17 in cartoon format, and we've got a green color that tells us how many chromosome 17s we are, and an orange color telling us how many copies of this HER2 gene are present in the cancer. So this bottom cancer has basically two green copies and two orange copies. That's normal. Whereas this top one has two green copies for 17, but it has a whole bunch, 6 or 8 or even more copies of the HER2 gene. And this turns out to be the way or the mechanism that most breast cancers get to overexpression of the HER2 gene. And finally, we started using newer assays that interrogate multiple genes simultaneously. The Oncotype DX assay is a good one, which is originally designed to try and stratify these early stage patients into those that might benefit from additional therapy to those that don't really benefit from additional therapy. And the big markers here, you can see there's this big set that are all about proliferation. So this proliferation to tell us whether it's a fast growing tumor or a slow growing tumor is a big part of this. Um, Most of our traditional chemotherapies work as essentially poisons to fast growing cells. And so they don't work as well in slow growing cells. And if you think about the way chemotherapy works, that means that we really want to reduce the toxicity of chemotherapy for those patients who aren't going to have a significant response to that chemotherapy. A few years back, we asked an additional question. Another gene expression assay is the 70 gene expression assay, developed by Laura Van Veer and her team here at San Francisco and at the Netherlands Cancer Institute. But we asked if we could set a more stringent threshold in that 70 gene prognostic assay to really try and find some of those super good prognosis tumors. Again, this is regardless of stage. So this could be a large tumor, but it's a slow growing large tumor and a low risk based on that. And we looked at these phenotypes. As you might imagine, the ones that score as ultra low are also biased towards being low grade, and the ones that score as higher are more likely to be high grade. So the grading and the gene expression profiles are related to one another. I'm not going to talk about it today, but there are special types of cancers. And again, the ultra low is enriched for some of these special types of cancers that we've long known have very good prognosis. So it's a problem that we're working on. We're trying to get to a point where we really are only diagnosing as cancer, and we really are only detecting cancers that are the true cancers that really deserve to have that word malignant in their definition. And these ultra low signatures probably don't qualify. They probably really aren't malignant. Some of these low stage, low grade, slow growing mammoprint ultra low tumors that we detect, maybe we shouldn't call them cancer at all because they don't have malignant potential. And so it's a chip away at problem. We have to eventually, what did Michelangelo say? I see the angel in the marble and carved till I set him free. And what he means is, and that's what we're trying to do. We're trying to get to the point where what we detect is really the true cancer, and everything else goes undetected, or at least if we detect it, we recognize it as being not true cancer, and we don't overtreat those patients for that disease. And I'm going to stop there and just take questions, but that's sort of what we're up to in Wisdom 2.0. We're trying to make sure that we can characterize those cancers that we detect in the study and try and determine whether we are detecting, again, an increased number by finding patients who are at high risk at younger ages and screening them more. Are we detecting more of the high risk, high proliferative rate cancers at an earlier time point versus maybe the patients that are at low risk and have less frequent screening? Maybe we'll do a better job of avoiding detection of these sort of non-cancer, ultra-low indolent cancers, and avoid, therefore, the overuse of biopsy in those populations, but also the potential for overtreatment in that population. And so I'll stop there.
Great.
What do you
Thank
think,
you,
Laura? Can we
Cindy.
figure it out?
Well, of course we can figure it out. I mean but I think it's an evolving, it's an evolving message, based on Rise Up. What I think is really important, I think about shared decision making at the crossroads of breast cancer and women's health. That it's not just important to know whether you're at risk for cancer, but it's important to know what type of cancer you're at risk for and what other conditions that you have, because that can help you prioritize how to think about prevention or treatment. And so I think, the message is if you are if you have a really tiny cancer that's really not going to be life-threatening and you have like a major issue and you're really having incredible difficulties with menopause or something like that or whatever, you're really not at that kind of risk. It's an easier decision about what you make, although still there are a lot of options to avoid taking progesterone and, things that you can adding estrogen is not necessarily a problem, but it really depends, and if you're at risk for hormone negative cancer, that what else can you be doing? How can you be thinking about it?
Yeah.
And
Yeah.
how can we combine treatments that may be good for you? Say you've got significant cardiac risk, maybe taking one of the new cardiac drugs, the PCSK9 inhibitors, which you don't need to know what the name of them are, but it's just like if they are, and if we prove to be anti-inflammatory and you know, they could be really very important because we know that some of the risk factors for breast cancer, that background on an MRI that lights up, some of it's driven by hormones, but some of it's driven by inflammatory changes. So if it doesn't get better with ABTM or some kind of endocrine manipulation, then we can add some anti-inflammatory things. And maybe it's good because maybe it combines because you've got heart disease in your family, or maybe, so I think there's, I think
So
the
yeah,
future is
I think
super bright.
the big picture message is breast cancer is not one thing. I mean, Laura's talking to this right now. It's so many different things with so many different permutations that you really have to be
More thoughtful.
specific and thoughtful about both treatment, detection, risk assessment. What kind of cancer are you at risk for? And we need to figure that out. And then prevention. Prevention's a big part of what we talked about at Rise Up. And how can we do a better job with prevention? I mentioned at the beginning, one of the things that we've begun to realize is really important is figuring out how the cancer evades the immune system. So bad cancers evade the immune system very well. Cancers that are not so bad don't really evade the immune system and can be held in check by the immune system. How can we help a person with their immune system to be better at keeping those cancers in check and support the immune system? So there's so many things that go into this. I didn't talk about it, but we now are looking at the biopsy and scoring those biopsies based on what we see the immune system doing or trying to do. Do we see lymphocytes infiltrating into the tumor, trying to keep a barrier up against that tumor? And in many sites, including breast, but also colon cancer, this turns out to be an important prognostic factor. Again, if the immune system does a good job at recognizing the tumor, your prognosis is better. And then the question is, how can we help the immune system do even better at holding it in check or maybe even eradicating that tumor? And so those are the new generations of immune therapies. We're trying to develop immune therapies and supportive therapies which with much lower toxicity than the current immune therapies. So there's a lot of room for improvement, is what I'm saying, but it requires that we avoid the mindset that breast cancer is a yes no thing. We have to think about each breast cancer almost as an individual with individual characteristics.
Sandy, there's a
Um,
question in the chat.
I love
Someone's
the
asked,
question in chat. I give
yeah,
whole talks on the question in chat. So, stage zero breast cancer, some people call it, is what's referred to as ductal carcinoma in situ. It's believed that ductal carcinoma in situ. So, first of all breast cancers start in the duct lobular tree. So they start from the epithelial lining cells. They don't start from stromal cells or the supporting cells or the blood vessels. They start in the duct. And so it's an epithelial lining cell that becomes the cancer. So in many cases, when that happens, there's a period of time where the neoplasm proliferates, but is contained within the ductal lobular tree and not invasive. And so for a long time, we had hope that if we detected women with ductal carcinoma in situ and treated it, and the way that we treat it is worth talking about. We treat it by trying to get rid of that part of the ductal tree that has it, that would prevent them from going on to get an invasive cancer. Well, it turns out to be a little more complicated. It turns out that only somewhere between 20 and 40% of cases of stage 0, even if we did nothing and left them alone, will ever progress. And so some ductal carcinoma in situ does not deserve to be called cancer, just the way some of those invasive cancers, it doesn't have malignant potential. But some does have consequences and some can progress, and that's why we treat all of it because we don't know any better. So we're starting to learn how to catalog our DCIS cases into those that really do need treatment versus those that don't need treatment or can do very well with maybe some hormonal treatment. And we have a new study for that called Recast DCIS, which is an opportunity to learn which preventions are really going to have good effect on that sort of potential maybe precancer. Um, I do get a little upset when patients who have stage 0 DCIS are told that they have cancer because I really don't think it's cancer. Um, at best, it might be precancer if left alone and untreated, but the prognosis is exceptionally good. It's up at that 100% level, the way I showed you the Kaplan-Meier plots for a stage 1A. So I hope that makes sense. Um, it's a confusing area and it's worth a lot more study, which is a big part of what we're trying to do here.
Thank you, Sandy. There's another question. Can scattered fibers in the breast turn into cancer in the future?
Yeah, so the breast is an interesting organ, right? It has a collagen supporting structure. It actually has some ligaments, we call them, that support the structure of the breast. And it also has adipose tissue, it has fat tissue, and it has those mixed together. The importance of the density of those fibers in the breast is the secondary one. It's not those don't become cancer, but the properties of those fibers can lead the potential cancer to be more readily invasive or less readily invasive. And so that's sort of the way we think about the fibrousness of the breast as being a risk factor contributing not so much to the intrinsic potential of the cancer cells, but to their environment and whether that environment contributes to their ability to spread or limits their ability to spread. So that's how we think about the fibers in the breast. Does that make sense?
Well, and I think it's important to know it's not let's take it maybe a step back and thinking about this is that what we're trying to do is try and understand who's got an environment. It's like think about neighborhoods. If you're in a neighborhood that has certain features that make crime more common or things, what you want to do is like, how can you clean up the neighborhood? How can you improve the inflammatory reactions, or how can you stop some of the hormone signaling, or how can you, and we know that breast density is one of those things that can support, um, that can support future development of cancers. And we know that background, some of this, enhancement that we see in the background of a breast on an MRI can also be fertile ground. But I think it also is important. This is one of the reasons why risk-based screening is such a important concept, because you can have a bunch of these things, but in total, you just may not have all the constellation of things that put you at high risk. And so it may not be really worth doing much to reduce your risk. But you might also be in the people who are definitely in the constellation of people at high risk. And there, you really do want to prioritize prevention. There are lots of things we can do. And actually, anti-progestins, progesterone's in the pathway of causing breast density. Inflammation is some of the things that can cause background. Even estradiol or Premarin can do it, or any of the estrogens can do it. but there are combinations of things that can actually relieve symptoms and reduce risk. So those are the ways in which we want to try and think about it. But really, it needs to be put in the context of who's at risk for what kind of cancer. And it's also true if you've had a cancer about what
Yeah.
decisions you make. Medicine is not a black and white. Here's the answer and here's not, or it's 100% this and no, it's not that. You're constantly making trade-offs. That's what good clinicians do that. And they do it with shared decision making, right? And so that it is really about, you're really trying to weigh what are my overall health risks? What is my breast cancer health risk? What did I learn about? Maybe you're part of the 10% of people who really should be paying attention, but maybe you're part of the bottom 40% that you're really in a low risk group. It's just not as much that's important. So those are what we want to think about. But I do want to say one thing again. I always say this. There is no risk assessment that's perfect. There's no diagnostic test that's perfect. You can be told that you're low risk and develop a mass. If you feel a mass and you feel something that's new, please go spread the word. Tell people it doesn't matter if you had a normal mammogram or a normal this or a normal that or a low risk. If you have a symptom, you need to go in and get it checked out because we aren't perfect at what we do. And we
Yeah.
always want to remind people that being familiar with your own body and being aware is your best defense. If you feel something new that's different, and people go, well, I'm afraid they're all lumpy, bumpy, my breasts are weird. Just get to know what they feel like. It's honestly 20 seconds, 30 seconds once a month. I can't tell you how many people come in and say, I just put my hand here and I felt this. This is still a lot of women find their own breast cancer. So it's no matter how good we get, we're always going to need you as the personal backup. You're on patrol. Just be aware. The UK has this great campaign that says be breast aware. Just be aware and look for things if you happen to see something and bring it up and come in. So that's my overview kind of
I
like
think that's
this.
really important too. And I actually showed that paper with the data on that. If you find something in the interval, it's more likely to be important and consequential. So, having those symptoms, they should not be ignored.
So
The other
Tina
thing
asked
I
Tina
wanted
asked a
to
question here. Does everybody grade and do diagnoses the same?
pretty close.
Pretty close, yeah.
We work very hard to be very consistent um across all of the world actually. So the World Health Organization spends a lot of effort putting out guidelines for everyone in the world to follow about um, different types of cancer and the grading schema and staging schema for cancer. And that's not to say there's not going to be some individual variability. There's always some subjectivity involved whenever two people look at the same thing at different times. But we do our best to reduce that. Um, I
And
was
I
going
think
to
it's important to know that sometimes, most things are pretty straightforward. I mean, most of them are pretty consistent, but sometimes you can have really complex things, really complex mammograms, really multiple biopsies or complex things. And having someone who's really going to go through and look through things for you can be helpful.
One of the things I always say is if you are diagnosed with cancer and you're considering having a second opinion, maybe you talk to one surgeon or one oncologist and you want to go talk to another one. Another really important second opinion is a pathology re-review. And a lot of what you're being told in terms of recommendations of what to do is based on that biopsy. And there can sometimes be differences. So it's nice to have an independent observer confirm the first pathologist's report and say, yeah, that all looks correct to me. Or there may be, and it may be subtle nuances, but they may turn out to be important in your case. So I think having a second opinion on pathology is not something most people think about, but I think it's something that is just as important as the idea of getting a second opinion from a doctor, an oncologist. Um, I want to cover, there's two other questions. One is about a very specific diagnosis called flat epithelial atypia. I'm going to change the question a little bit and just talk about atypia in general. So sometimes we see something that doesn't count as that stage 0, but it also doesn't look quite normal to us under the microscope. And so we've used the term atypia, not typical, atypical, to describe those. And in most cases, what that means is um, that's a marker. That's like a way of telling that, hey, something's going on in this person such that their breast tissue is reacting in a new way. And what we've learned is that that turns out to be a way to enhance or add to our calculation of your subsequent breast cancer risk. And that doesn't mean that it's a precancer. There was a lot of hope for that. What it means, though, is that it's a marker that something is reacting in an atypical way, and that puts you at increased risk for breast cancer. Flat epithelial atypia is kind of the newest kid on the block when it comes to atypia, and it has the weakest tie to eventual breast cancer risk. Um, so it's, um, if you compare it to atypical ductal hyperplasia or atypical lobular hyperplasia, there the increased relative risk is well established, but for flat epithelial atypia, it's very poorly established. So does that mean it's normal? Well, it's probably not normal, but it's also probably not very meaningful on an individual basis. And then Diane asked the loaded question about lobule versus duct. Um, so these terms are a little bit historical. And so when pathologists, maybe almost 100 years ago now, first started seeing these under the microscope, they sort of thought the lobular neoplasms, the invasive lobular cancer, or the lobular carcinoma in situ had a cytology where the cells kind of looked like cells in the lobule. And that's how it got its name. And similarly, the invasive ductal carcinomas and the ductal carcinoma in situ, the cells looked a little more like the cells in the duct compared to the lobule. And so they got these terms historically. But we now know that the most likely cells of origin for breast cancer are cells that live right in between the duct and the lobule in what's called the terminal duct or the terminal duct lobular unit. And if you think about it, that makes sense because that's where the cells are that are going to be the most stem-like. That is, they're going to have the potential to become a lobule cell or become a ductal cell. They have a lot more intrinsic plasticity, and that's a feature also of cancers. So those are cells that are more likely to become cancers that are in that terminal duct lobular unit. Um, but they all start in the epithelium, not in the stroma. And I think what we're finding, just to add a little fuel to the fire of this in situ versus invasive, is that when we see in situ and invasive at the same time, they actually if we were able to go back in time, they actually arose together. So the invasive cancers are happening much earlier than we ever anticipated. It's not so much an issue of an in situ cancer being there for a long time and eventually becoming an invasive cancer. That seems to be uncommon compared to the much more common scenario where something that starts in the duct immediately becomes invasive, but also grows in the duct. And what Laura and I have been studying in another cohort is what happens when it stays in the duct? Why does it stay in the duct? Why does it sometimes get very large and grow very rapidly, but not ever learn to invade? And you can think about that just like the potential, right? So there that neoplasm, that new growth was sort of born without the potential to become invasive. And so it became very large. And that's not to say that it couldn't eventually evolve with the wrong constellation of mutations into an invasive cancer. It's just got to do that as a next step, which may or may not occur. I think it's time for us to change a lot of the nomenclature. If Laura gives me enough time to work on it, I'm going to rewrite the breast cancer textbook so that we have a whole new set of terminology that more accurately reflects the different types of breast cancer and their important consequences for treatment.
Excellent. We have a couple more minutes if there are any final questions? Otherwise, we can wrap up. And
Was this helpful? Was this helpful to people?
It was amazing. Thank you. I asked if it's possible to comment on role of AI in pathology, given that its capabilities is the pattern recognition. Thank you.
Yeah, it's very good at pattern recognition. I think I also give a whole talk on AI. I could come back and give that talk to you guys. You might enjoy it. My take on it is that AI has the potential to give me tools to make me um, more reproducible, to avoid some of that inter-observer variability, to make me more efficient so that my counting and measuring can be done accurately but also quickly. And that anytime we're more efficient in medicine, that reduce costs or has potential to reduce costs. And so those things are important. I also think, though, that it's important for the pathologist to be on top of those tools and the pathologist to be involved or supervising those tools. I am not comfortable. I think most of the patients I talk to are not comfortable turning it over to an AI without that supervision. But I think most of us are comfortable having those tools become available for efficiency, reproducibility, quality, etc.
Yeah, we'd love to have you back to talk through that. I think that would be great. And I know
Yeah.
you alluded to this in the initial part, but as we continue on with refining our risk assessment and wisdom, we're working on new ways to engage our participants, particularly those who have had biopsies and had a diagnosis of breast cancer, to get access to those pathology images. And if they're not available digitally, maybe the actual slides so that we can do this deeper dive. So that is coming up. We're trying to think through the protocols and the workflows and the messaging to our participants to make sure that it's as easy as possible. So that is coming up soon. We'll get in touch when there's more information on that. But big thank you, Sandy. Thank you for joining us. Thank you for the very informative discussion and overview of breast pathology and making it more approachable. I know a lot of these words and topics are sometimes confusing. So we will be sure to share this recording. If there are pieces of this that you want to listen to again, we'll share the recording on YouTube. And also the survey is in the chat. We can post that again. If you have comments either about today or future topics, we always love to hear and get your ideas of what you want to hear about next.
I also said, I think this idea about thinking about prevention and why we should be thinking about trying to, lean into prevention in the 10% or so of people where it really matters the most, I think is really important. One of these forums, we also talked about our Duave study, which someone on the listening on the forum then joined the study. And, at the end of the day, can make a big difference. I'm also very happy to talk about kind of reframing DCIS as an opportunity for prevention, because it's really, I think, again, in situ disease is sort of part of the spectrum of DCIS. So it's, again, what can you do when you have something like that? Are there things that you're doing that are contributing to your risk that you can reduce that risk? What are the kinds of things that we're trying to do to think about how to study prevention more intensely at this moment to find better options for people, going forward that are more tolerable. So
Yeah,
happy to talk about that again. We talked about the best, but I'm happy to talk about it again.
Yeah, and that's actually our topic for March, which is on March 30th next month, is recapping the Rise Up conference, which, Laura, a lot of what you just talked about were topics that were discussed at Rise Up. So I think we can sort of frame that in the context of this 1 hour discussion.
Wow, recapping in an hour. Okay, come on.
We'll take one of the sessions and
it was only a
recap, maybe
3-day
on
meeting.
prevention. Yeah, what you just talked about around
Crunched
prevention.
into like a 4-day meeting, crunched into 2.5. Yep.
Yes. So lots of great information. So the next forum is Monday, March 30th from 4 to 5 p.m. Pacific time. Your registration for today gets you registered for every future forum. So we look forward to having you join us. And please do share the word. We'd love more people to join these or share the links to the YouTube channel. Again, we want to make sure that these are open and accessible and available to everyone to join. So thank you so much. Thank you again, Sandy, and I hope everyone has a wonderful evening.
Great. Thank
you so
you.
much.
Thanks for coming.